So, as we prepare for our panelists, I'd like to first tell you a little bit about them. We're going to hear from Brian Dixon, who will talk to us a little bit about a health information exchange. I guess Brian is the Peyton Manning and the Tom Brady of HIT, and he's found a few receivers in Indiana. So he's going to tell us a little bit about the health information project for in moving data across the NHN. We also have Carolyn Scott, who is a provider from Premier Healthcare System, and she's going to talk to us from a provider's perspective related to health information technology. She's the Vice President of Performance Improvement and Quality in Premier Incorporated's Informatics Division. In her role, she has oversight of strategic direction and planning and execution of the Quest initiative, which she'll tell you a little bit about. And then we will conclude our panel with Regina Holliday, who is a patient advocate. Regina is a DC-based patients' rights arts advocate. She's currently working on a series of paintings depicting the need for clarity and transparency in medical records. She placed her first mural in a series in May of 2009 after experiencing a great loss, which she'll tell you more about. Now, before Brian starts, I would like everybody to take out your cell phones. Now, I know usually at a conference when you take your cell phones out, we are asking you to turn them off, but I'm asking you to turn your cell phone on. And we're going to put up a polling question. Since this is a HIT plenary, we thought we'd use all means of collecting data from you. And you heard when Dr. Blumenthal was speaking, he spoke about a number of barriers that exist to exchanging information across the country. I wanted you to think about where you live and the area that the people that you work with, and think about if you could remove one barrier to health information exchange in your state, what would it be? So on your phones, then you're going to text to 22333. If you think it's privacy and security concerns, you're going to put in the body of your message the number 1 and PRIV. If it's not enough providers that have electronic health records, you're going to put the number 2 and the letters EHR. And then if it's inadequate infrastructure, you're going to put the number 3 and INAD, or other, which is 4 other 1. Give you a minute or so to figure all that out and text in your answer. You did pretty well with that. And we see that you think at least 52% think inadequate infrastructure is the greatest barrier in your state. So thanks for that, and we'll be back with more of those. We're going to turn it over to Brian just to talk about health information exchange.
All right, thanks, Jean. Although in Indiana, we typically don't use both Tom Brady and Peyton Manning in the same sentence. Yeah. But I do think that Drs. Straub and Blumenthal really provided me, to use another sports analogy, with a great assist in their talks prior to mine. So what I'm going to focus on today is covering health information exchange and really trying to make the case that HIEs, many of which are developing across the country, thanks in part to the large funding provided by high tech, that these really are crucial players in advancing quality. Next slide, please. All right, so talk about our Indiana Network for Patient Care and then a couple of the programs that we're doing in Indiana that I think are really helping to build the foundation that Dr. Straub talked about. So this is a high-level overview of what I mean by health information exchange. So over on the left-hand side of the screen, kind of at its fundamental state, HIE is about different players in the healthcare system basically making their data available to one another. So in Indiana, our providers, which include hospitals, laboratories, public health departments, physician practices, and now also ambulance services, are putting their data into a common repository that's hosted at the Regan Street Institute where I work. And what is involved in the middle of that are services, applications, and data repositories that really manipulate the data in terms of codifying it, making sure it is normalized to standards like LOINC and CPT, ICD-9, SNOMED, et cetera, and that we also store it in a way that creates sort of a single picture of the patient's healthcare record across our health systems. Just to give you kind of the overview of kind of patient overlap in our community, we recently just completed a project with the VA where we were looking at patient overlap, and we found that out of our Indianapolis VA Medical Center, 83.9% of their patient population had received care in the private healthcare sector within the last year. So there really is a strong need for sharing information across silos. And then over on the right-hand side, once we have built this common infrastructure, this foundation, we can do a lot of very good services with it, like results delivery, such as discharge summaries immediately to primary care physicians after discharge. And in the long term, we can also create de-identified data sets for research. So this is the Indiana Network for Patient Care. Some of the high-level points I just want to briefly mention is we think of it as a virtual patient-centered record across healthcare providers. We have shown in research studies that it can lead to reduction in duplicate testing, improve medication list sharing, and have an up-to-date, accurate medication list. We can also share data between inpatient, outpatient, and ED settings based on various clinical triggers, which are always paramount to ensure that you as the provider who's accessing the HIE has permission, you're seeing that patient at that time. And of course, the HIE can lead to achievement of meaningful use, as Dr. Blumenthal discussed. Here's the scope of the IMPC today. We basically cover 80% of the patient population in the state of Indiana. We go all the way up 65 between Chicago and Indianapolis, across 70 to Terre Haute, down to Evansville. But most of our activity is in the central part of the state, where the 5 largest healthcare systems in the state are located. We have several services that we offer to our partners. The first one provides real-time data feeds of chief complaint and other data from emergency departments directly to the state health department, which is then shared out with local health departments for accurately surveying for emergent threats to public health. The second is what we call Docs for Docs, which is our clinical results delivery system that touches 19,000 physicians today in the state of Indiana, delivering laboratory results, radiology reports, pathology reports, discharge summaries, et cetera. Then we have our CareWeb results viewer, which provides access to the longitudinal record to physicians in inpatient and emergency department settings to allow them to look at recent test results, trend things over time, as well as access data from our newest partners, which include long-term care settings. And finally, Quality Health First, which I'll come back to at the end of the presentation. Next slide, please. But I do want to mention a recent project that we just finished with CMS. And I think this slide probably looks familiar after some of Dr. Straub's slides, and that's a good thing because on the left-hand side, it doesn't matter whether you're a physician practice or a hospital or an end-stage renal disease facility. It really what we've been working on for the last year or so is the development of standards for interoperable communication from the left side of the screen to the right side of the screen. So moving data, clinical data, from electronic health record systems through the Health Information Exchange across the nationwide health information network to CMS. And we really have, there's been quite a number of people, not just the Regenstrief Institute, who have contributed to the development of these standards, which really are laying the foundation for this type of information exchange in the future. And at the bottom there's some references to some technical standards. I'm not going to go into the details this morning. On the flip side of that, it's not just reporting clinical data to CMS for measure calculation, but it's also about getting reports and feedback delivered back to the providers who submitted the data. So in this way, we've also been developing standards. It's a different set of standards and technical specifications that are required for delivering the reports back out to providers. But we've also been working on that to ensure that the feedback, the 10 level, the NPI level reports that CMS produces are delivered back to the appropriate individuals in physician practices that are participating in the project. And this is what we can do once we've got a common infrastructure through the Health Information Exchange. Not only can we do all of the services that were on the first slide, but we can also start to do a lot of things to move the needle in the direction of improving quality. So in Indiana, through our Quality Health First project, what we're doing is we're providing patient summaries of clinical quality data to providers on a quarterly basis, and we're also providing them with a performance summary. And this is a program that they can sign up for through several payers. So it's a multi-payer program that includes CMS, but it also includes private insurers. It's helping physicians to identify early and prioritize things to move the quality needle. We're focused initially on cancer screenings, diabetes care, as well as heart disease. And today it serves over 1,400 physicians in our community and covers over 900,000 patients. Also, I should mention that no EMR is absolutely required for participation in the project today, because as a health information exchange, we're getting real-time electronic feeds directly from laboratories, directly from payers, directly from other service providers, so we don't necessarily have to have the physician's EMR today to feed data into this system. We're certainly moving in that direction by working with our regional extension center and with the other organizations in our state to increase adoption of EMRs, but today it's not a requirement. This is an example of one of the reports that we give to physicians on a quarterly basis that shows their performance in the blue bar against the adjusted peer score in the gold bar. And this is for our measures across cancer, diabetes, and heart disease. We also give physicians a detailed patient report that allows them to do a couple things. First of all, it helps with patient attribution, so they can tell us that's not really my patient, or the patient is now deceased, and they can feed that information back to the Health Information Exchange. It also allows them to enter data that we may have missed because the patient went to a provider who's not part of our network, but the test was done, or the foot exam was done, and so the physician has a place to document this very quickly and efficiently and return it back to us so we can feed it back to future quarters. All right. And so what this slide is conveying is that it goes back to the points that Dr. Straub and Blumenthal discussed, which was simply that to get to where we all want to be in moving forward the needle on quality, we have to build a foundation. We're doing that today. Not everything is in place to get there, but a lot of people are actively working to move in this direction. And what I would like to see on Dr. Straub's slide next year in that list for the physician quality reporting system slide is not just EHRs and registries and large and small providers, but also health information exchanges, because I think that HIEs can be a critical partner in moving forward the needle on quality that requires some foundation foundation building that we're doing, that other states are now doing with the money from high-tech. And once we have laid that foundation, then we can continue to add services such as surveillance systems and quality reporting systems and clinical decision support. So we're moving in that direction, and there's more work, obviously, that needs to be done. So those are my comments on where we're at with health information exchange, particularly in Indiana, and how I think that HIEs can work with QIOs and others to continue to push forward this idea of improving quality in our healthcare systems for all of the service providers in our area. Thank you.
Thank you.